Thank you, Matt. It's great to be here, and I am not, I'm a little bit worried about this lecture, actually. There's been a lot of questions about the guidelines that came out, and while I didn't write them, I was involved in the oversight of these eventually getting published, and I'll go through a little bit of that with you. These are my disclosures for those of you want to see. Some of these may be relevant here, but as most of the statin therapies today are generic, I have not been a consultant to any of the generic companies. So I thought I'd start with a case because I think it's easy to argue about the academics of everything. So this is actually a patient I saw around about October 12th, which is a few weeks before the guidelines. 63-year-old professor of psychology concerned about statins, coming for a second opinion. He has a prior history of atrial fibrillation, diagnosed in Chicago in 1998. He had a normal stress echo in 2005, subsequently had AFib ablation, followed by a few months later by flutter ablation in October 2008. And he actually has done very well since that time for atrial fibrillation. He's in normal sinus rhythm. He's actually not anticoagulated now. And he had a workup just prior to leaving Chicago in 2012, which was a repeat stress echo, which was also normal. And in 2010, he was diagnosed with hyperlipidemia. So he has no family history of coronary disease. He has no prior history of coronary disease, cerebrovascular disease, or peripheral vascular disease. He's a non-smoker. His BMI is 25.2, and he's got a normal blood pressure. As I said, his hyperlipidemia was diagnosed in 2010. We don't have those numbers, but in 2012, when he came under our care or Duke care, his cholesterol panel was shown here. Total cholesterol 211, triglycerides 155, HDL 40, and LDL 140. At the time, by his primary care physician, he was recommended a diet and a statin. Patient refused this therapy, so he went on diet alone. And when I got to see him in this year, his cholesterol number had improved slightly. I think fairly consistent with what you can achieve if you're relatively thin with dietary modification. Total cholesterol fell to 208, triglycerides unchanged at 154, HDL went up a little bit to 45, and his LDL was 132. So the question I have, should he be treated with a statin? So show of hands, how many of you would treat this gentleman with a statin right off the bat? Nobody. Is that fair? Okay. All right, so nobody would treat him with a statin. That's good. We'll move on. So 2012, this whole controversy about how aggressive to treat patients who are otherwise well without vascular disease. And this was actually played out in JAMA. I don't know if Eric Peterson is here. You may have some insight of this, but it was a debate between Roger Blumenthal from Hopkins and Rita Redberg from University of San Francisco, University of California in San Francisco, and basically it was a low-risk gentleman and sort of similar to the case I presented to you, and there were two different viewpoints. That played out in JAMA as well as in the Wall Street Journal that was published a little bit later the same year, discussing these two very strong opinions for and against. Fast forward to this year, and actually 2 weeks ago, this is the Wall Street Journal on Wednesday, November 13th, 2 days before the AHA meeting starts. Headline is Strategy to Cut Heart Risk Receives a Major Shakeup, and it refers to the new guidelines that I will address a little bit with you today. CNN was not far behind. Sanjay Gupta, you can see there he's trying to explain the statin story. The ever-present Steve Nissen says this is an enormous shift from the Cleveland Clinic about these guidelines. Heart.org, not to be outdone. How good is the new risk calculator, focusing on one of the issues in the guidelines that came up, and Dr. Paul Ritker and Nancy Cook shared unpublished data with Heart.org about the difference between their assessment of the risk calculator and that produced by the ACCHA in this setting. New York Times, first page article, risk calculator for cholesterol appears flawed based on Paul Ritker's data that he shared with the New York Times ahead of publishing it. Dr. Nissen again, it's stunning. We need a pause to further evaluate this approach. So here are the things, and finally USA Today comes out and says, uncertainty here, who should get it, and the experts undergo a debate. I should point out that for those of you who stayed at the AHA beyond Tuesday, there was actually a Wednesday morning session where all the guidelines were presented in a special forum, and the writers of these guidelines presented their case and why they think it's a reasonable thing to do. So before we get into this, I think it's really important to recognize that the guidelines are changing. So these, ATP4, they would have been called, had NIH continued it, essentially are now under the auspices of the American College, American Heart Association. This happened because the NIH decided back in the spring, when the guidelines were completely written, that they would no longer endorse and continue working on them, and basically backed out, leaving the American Heart Association with really no other option but to pick them up, because start de novo would have been bad. They then went through a peer review through the Guidelines Oversight Committee and the leadership of both organizations. But what I want you to remember is that the reason this has come about and the reason they're different from what you've seen before has nothing to do with these guidelines, but really about the Institute of Medicine, which I will review with you a little bit and discuss the new methodology for guidelines. I'm going to share with you just a tiny bit on the investigation behind residual risk, which I think is pertinent to this group, and then share with you really the key concept from the prevention cholesterol guidelines. I'm not going to be able to cover exercise, obesity, and the other aspects in interest of time, and I'm hoping that Dr. Blasing, Dr. Patel, Dr. Krause, Dr. Guyton can lead us through a discussion to find out what the right thing is to do here. So this is the ACCHA guideline that you're all familiar with. These guidelines basically are classified into 3 classes, 1, 2, and 3, with 3 different levels depending on the types of investigation carried out, level A, B, or C. C represents expert opinion. Level A, typically multiple randomized clinical trial, and everything sort of in between is level B. Class 1 is useful and effective, so benefit far outweighs risk and is highly recommended. Class 2 is a little bit in between. There's some benefit over risk. It's reasonable to recommend, is 2A. 2B is possible benefit, risk may be considered, and class 3 is not useful, should not be done, even may be harmful in some settings. So that's the ACCHA guidelines in this setting. Pierluigi Tricoci published this paper in 2009 with Eric Peterson and Sid Smith, and looked at the scientific evidence underlying the ACCHA clinical practice guidelines. And what you can see here, level evidence A, so that the best evidence that we have is relatively lacking. Of all the recommendations, 26% in heart failure guidelines were level A, 22% in secondary prevention, UA STEMI, 23%, and CABG, 19%. So fairly 1/5 to 1/6 of all the guidelines, or 1/4 or so, have good evidence. The rest of it is based on relatively poor evidence. I want to point out that there's some areas, such as valvular disease, where we really have so little randomized trial data that is basically mostly based on expert opinion, as I will show you in a little bit. But you can see the breakdown here in this setting. It's important to remember this when we look at the new set of guidelines that I'll share with you in a second. Now, what about level evidence C? So this is basically expert opinion, really very little randomized clinical trials or even trial setting. And you can see here, for some guidelines, atrial fibrillation, stable angina, valvular disease, and pacemaker implantation, it's actually fairly all expert opinion in this setting. So that's what the guidelines traditionally have shown over time. The Institute of Medicine came out in 2011 with this statement: clinical practice guidelines we can trust. And they set out a number of principles. This document, I should point out, is about 300 pages, so I'm not going to get through it all. But I'm going to hit some highlights and share with you how the American College and the American Heart Association had addressed some of the flaws. I've already pointed out 2 flaws to you. One is that most of the guidelines are actually not based on randomized trial data. And the other flaw is that it's mostly expert opinion. In this document, they say we have to do away with expert opinion as a principle for guidelines. Otherwise, we will not be able to trust them. At least that was Institute of Medicine's point of view. So the American College and the American Heart Association got together, and I know this is a paper that everyone has read, I'm pretty sure, actually produced this guideline methodology paper that was published earlier this year in the summer, and actually where they got together to define how should we address the flaws and the issues that the Institute of Medicine pointed out, and merge them with the ongoing ACC/AHA guideline work that, as all of you know, has been going on for nearly 20 years. So there's a lot of experience here. And you can see the group who was involved creating this document. Basically, a number of issues came up, and it was divided into 5 groups. And I'm going to just highlight a few aspects. The first part, if we can really trust the guidelines, we need to do a couple of different things. We need to reduce the amount of influence of conflicts that occur, and therefore the Institute of Medicine would like to see that nobody who has consulted or participated in any clinical investigation should be on a guideline. That's basically non-experts, another way of saying that. ACC/AHA actually doesn't agree with this. They think there needs to be a balance. The other aspect that the Institute of Medicine had recommended is that there should be a patient representative. And in fact, this is part of the things that it says on this piece of paper, is that they actually are going to bring in a patient representative to be part of the guidelines and help form them in the appropriate ways. Another important factor that the Institute of Medicine has pointed out is that we need to systematically evaluate the evidence. And basically, you need to, in order to get the best evidence and understand it the best, you actually have to do a systematic review of the evidence. It's slightly problematic if there's only one trial, because there basically is only one trial. But in many areas, there are many, many trials, and combining them in a systematic way with the appropriate methodology is what recommended. And ACC/AHA is actually moving to that. And so you're going to see many more meta-analyses that have been scientifically performed correctly that actually will be incorporated in the guidelines of the future. How are you going to find and assess the evidence to which you include in the guidelines? Most of you may know, but who are participating in guidelines, actually this is mostly by recall. It's really hard, though, to recall every piece of evidence, particularly as we now have 5 circs, 5 JACs, and a few other major journals that are in multitude. So basically, one of the sections in this updated is that basically an appropriate Medline search and for every question has to be done. This is fairly labor intensive because some of the keywords and some of the pieces that you have to put into this becomes quite important. But this is really defines the standard for assessing the individual studies and how to use this approach using a objective abstractor to look at the data in certain ways. How do you synthesize the evidence? Basically, mostly through meta-analysis, but there's a lot of issues that it needs to cover. Risk of bias, consistency, precision, directness, reporting bias. So those are issues that the new guidelines will address as this is moved in, and basically to deal with some of these issues. And you will see some of these issues come up later on in my discussion. And finally, how do you incorporate this? It's regular evidence that we take one trial here or one trial there versus the systematic review. So one of the things that are recommended is that the systematic reviews, when they go into guidelines, will achieve a different level of connotation or notation so that everybody knows that this is systematically obtained using the standards of Institute of Medicine. The ACCHA recognizes that this is a very long process, and it's going to likely take better part of 5 to 6 years to incorporate this process in all the guidelines. Now, going back to this, recognizing that I said that we're going to have guidelines that are fairly narrowed focus because we're going to mostly deal with randomized trial. Just to give you a guideline that most of you know because you practice it every day, UA and non-STEMI. And if you look at 1A, that's only 27%. So what that means, if we were to follow Institute of Medicine completely, the guideline will shrink dramatically, and there will only be that many recommendations. Now, I don't think that's going to happen, but you can see the importance of this. And when we come to talk about the cholesterol guidelines, that's to some extent what has happened, because they've been shrinking down to focus on the one area where there's evidence. Guidelines are not static, so what you see here is actually the change in the UA non-STEMI guidelines between 2007 and 2011. You can see the number of recommendations actually have gone down. Number of pages have gone down dramatically. Figures and tables also much less. And you can see now that we're getting into and updating it on about every 2-year basis with updates, which means that they're really going to be hard to be out of date. With the ATP3, 10-year spans is just not really feasible to do. It's not appropriate for practice either. So this is going to fall into the categorization. Now, there are people who don't believe in guidelines, so I had to put this paper in by Eric Peterson, who believe that guidelines are not important. This actually shows from the Crusade Registry, Eric's paper published a few years ago, linking hospital composite quality from the best to the worst. So the best is over 75% hospital composite quality, and in-hospital mortality, adjusted and unadjusted for the types of patients seen, and you can see there's a stepwise relationship. And if you improve your guidelines, for every 10% improvement in guidelines adherence, you have a 10% reduction in mortality. So at least with the UA and non-STEMI, we can say adherence to guidelines is important, and it lowers mortality in this setting. Now, having given you all of this, this is actually a survey by about 5,000 cardiologists in the United States. This has not been published. This is from the ACC. And it asked a simple question: how many times do you use the guidelines? It's actually interesting. 69% said most cases. Only 15% in some cases or less. So I think that speaks well for the guidelines and how people follow them and how they're used. What do they typically use? Well, this is now the different types of guidelines that you can look at. And obviously, some of these would not be relevant. For example, the UK NICE Institute, shown here, it's not appropriate for our country, but nevertheless, sometimes they're used. You can see the US Preventive Services Task Force that have come out with their own lipid guidelines. Actually, have not, by and large, been followed. So really, it's the ACC, AHA guidelines that are used and followed in practice. Now, the big question, though, is I said that the C guidelines, those that are by expert opinion, they don't have data behind them. But should we do away with them? In this survey, actually carried out in the spring of 2013, you can say that it was a question laid out here, but the basis of it is that 71% of physicians surveyed felt that having these expert opinion was helpful for practice. So 71% felt that was important. Now I can say that the guidelines that I'm going to touch upon in a bit, they actually don't have any of these C guidelines or C recommendations. So that's obviously reason they may be controversial. There is really no guidance for several areas. Now what about the class 2B, the sort of may be of benefit? Interestingly, even those are liked by the physicians. 66% actually prefer them and to have them included in the guidelines of the future. This is in stark contrast to the Institute of Medicine. And then finally, the most controversial area, and that is, should we incorporate cost in guidelines? And this is, has really deals with cost effectiveness. And Dan Mark, if he's here, he actually is on this, and there will be a paper coming out early 2014 that will give guidance how we incorporate cost in our practice of medicine. And you can see physicians really would like to see that already, which is terrific. So let's just a few words on investigation on residual risk. Well, let's just first say that we've done really well with lowering cardiovascular mortality in the non-diabetic patients, basically a 50% reduction over the last 40 years. In the diabetic population, not so much. And you can see that they have a residual risk that's fairly substantial in this setting. Many times, as you know, the diabetic patients have normal lipids, and so the question will come, can we do better in this group of patients? There's a fairly striking correlation between cardiovascular events and LDL levels on mean concentration, and this is in, I apologize, this is in millimoles, but basically showing a very striking linear relationship in those trials for primary prevention, which are shown in red down here, secondary preventions shown here, and then diabetes secondary prevention shown up here, and then you can see the diabetes primary prevention falls really on the line of the secondary prevention. And in the ATP3, it was called a coronary equivalent having diabetes. So you can see, this is old data now published a number of years ago, but you can see a striking relationship. Yet, if you practice in the hospital and you walk around and you say, okay, patients are admitted with cardiovascular event first, cardiovascular event, about half of them, a little bit over half, actually have normal lipid levels, yet they still have an event. So somewhere along the line, we're not actually achieving the goal, even achieving the normal lipid levels, LDL less than 100 in this particular case. And you can see this is based on about 136,000 hospitalization. So we obviously haven't reached exactly what we need to do in this setting. One other way of looking at this is actually to perform other analysis of your lipids outside your standard lipid testings. And in this, just shown here from the Duke clinical labs, is the LDL particle number distribution with the concentration less than 100. And you can see that in 37% LDL and the underlying particle number for LDL is concordant, 37%. But in 63%, it's discordant. That is to say, another look at your lipid profile provide information that shows that it's not normal in this particular patient, as it should be if LDL was the true answer to this. So the guidelines that I'm going to share with you are essentially boiled down from a lot of publications, but this is one of the key publications. This is probably the most scientific, rigorous meta-analysis of all the lipid trials where they had individual patient data. It's called the CTT, Cholesterol Treatment Trial List, based out of Oxford, but basically looked at all the different trials and its relationship. And this is one of the key tables from that publication. This looks at statins across LDL levels using this combined analysis. And you can see on the top bar, you can see more versus less statins up here, statin versus control, and all trials combined, looking at the various cut points, less than 2, over 3.5 for cholesterol levels, and what you can see, it's fairly uniform. When you combine all the trials, the evidence is across all the different baseline lipid levels that are shown either in more versus less statin or statin versus control. So a very consistent message as far as the benefit of reducing cardiovascular events in this setting. Most relevant, though, for the question about should low-risk patient be treated is from this meta-analysis. So this is a subgroup now, reanalyzed to the trials that I showed you on the previous slide, 27 randomized trial from the CTT. And here, same analysis again. This is a number of events, prediction, or number of events reduced by statins. On top, participant without vascular events. In the middle, participant with vascular events, and then all together. And what you can see here is that in these patients, the low-risk patients, less than 5, less than 10% of risk, either for primary prevention or for secondary prevention, it's a very consistent message, i.e. the number of cardiovascular events are significantly reduced in this combined analysis in this setting. Now, the biggest issue has, of course, been side effects as well as cancer or total mortality or cancer mortality. And what you can see here, I just picked one, which is the cancer incidence and cancer mortality. There's no signal that even among the lower patients, there is a significant increased risk with taking these medications. Now, there is muscle issues that occur in about 4 to 5%, depending on how you define it. But other than that, basically these drugs are felt to be very safe in the overall setting. So now let's get to the guidelines that were presented, and this is actually from Neil Stone's presentation that he gave on Wednesday. Here is the blood cholesterol guideline, panel members, Neil Stone, Jennifer Robinson. Jennifer actually wrote most of these guidelines, and you can see the other individuals involved here, including Sid Smith. Actually, Peter Wilson, some of you will remember because he's a Duke graduate from a number of years ago, but he's most famous for his work on the Framingham study. So the NHPLI charged this expert panel to evaluate higher quality randomized control trials, evidence for cholesterol-lowering drug therapy to reduce the risk of cardiovascular events. They were asked to use critical questions to create evidence search from which the guideline is developed. This is now going to the methodology that I described earlier. They had a cholesterol panel, they have a risk assessment working group, they have a lifestyle working group. They only evaluated randomized clinical trials, systematic reviews, meta-analysis of randomized trials, and they were independently assessed to be either fair to good quality. And they were asked to only make recommendations on the randomized clinical trial evidence. They had a number of entry criteria, how they evaluated this with inclusion-exclusion criteria. They developed an independent contractor who did all the search, all the things that I told you earlier. And then basically, the overall literature search was from January 1st, 1995 through December 2009. So we're only 4 years behind, although they did include some trials up until July of 2013, but realistically, there's no evidence generated after 2011 based on this work. The NHA-LBI grading system is different from the ACC-AHA, so it's important to point that out. Grade A is strong recommendation, B is moderate, C is weak, D is against, and then E for expert opinion, or if there's conflicting data. And much of what I'm going to show you are A and B. That's basically what they have focused on. And then there is some statements in the overall guidelines that are no recommendation for or against, so neutral statement. They also rated it as high quality, moderate, and low quality. You can see here it sort of depends on how the trials were carried out, if they represent the population, highly certain about the estimate effect, which means large sample size, and basically moderate is minor limitations, maybe affecting the confidence with these trials, and then low grade is randomized clinical trials with some major limitations. What I want to point out again, there's no other data than randomized trials. So if you have no randomized trial data with outcomes in the setting, you are simply not included in this analysis. So the statin benefit group has been summarized for, first of all, patients with clinical disease, so typical secondary prevention after cardiovascular disease, patients with peripheral vascular disease, or patients with cerebrovascular disease. Patients who have an LDL at baseline over 190 without secondary cause. Patients with diabetes that are treated for primary prevention between ages 40 and 75, and an LDL 70 to 189, because that's the group that are not covered in the other two. And then the group that our patient falls into, which is primary prevention, no diabetes, 40 to 75, lipid values there, and where the risk is over 7.5%. So the guideline scope is to focus on treating blood cholesterol to reduce the risk. It's also to emphasize adherence to heart-healthy lifestyle, and there's a whole section on that I'm not going to have time to cover. But it's also there to identify individuals most likely to benefit from cholesterol-lowering therapy, and there's basically 4 statin benefit groups that I went over with you, and to identify safety issues. Why did they do away with the targets? Well, it turns out that there's really no evidence to support titration of drug therapy. In other words, there were no randomized trials that were carried out with the specific idea of titrating the therapy that was large enough to be included in the guidelines. Paradoxically, there are 2 ongoing trials with injectable cholesterol-lowering agents that are doing just that. So we may have to revisit this decision, or the decision may have to be revisited based on those trials when they become available in about 4 or 5 years' time. There's strong evidence that the appropriate intensity of statin therapy should be used to reduce the cardiovascular risk in those who are most likely to benefit. There's a quantitative comparison of statin benefits with statin risk, and non-statin therapies have not to date provide sufficient risk reduction benefits or safety profiles to be comparable to statin therapy, and that's why they're not included. The difficulties with using to treat to target, the current randomized trials do not actually really tell us what the target should be. It gives them a guide because that's where the patients ended up. The unknown magnitude of additional risk reduction with one target compared to another, an unknown rate of additional adverse effects for multi-drug therapy to achieve a specific goal, and therefore it was felt to be not possible to come up with a net benefit from treat-to-target approach. So here is this thing, and I printed out the guidelines for those who want to look through them. They're long. But here are basically the bottom line. Patients should be started on healthy diet and exercise and so on. And if you have clinical cardiovascular disease and you're under age 75, you should be a high-intensity statin therapy at the max tolerated dose. And I'll come back to that, what that means in a little bit. If you're over 75 and you're not a candidate for high-intensity statin, it's reasonable to start moderate-intensity statin, and I'll share with you a little bit what that is. If you have LDL over 190, irrespective, you need to go on high-intensity therapy. And if you have diabetes, type 1 or 2, between 40 or 75, and you're not covered by the other two, you should start with moderate-intensive statin, except in the setting where you actually are at high risk, and I'll come back where it's reasonable to start high-intensity statin. Now, how do you define high and moderate intensity? High intensity is a therapy that actually lowers your LDL cholesterol by approximately 50%, and the moderate by 30 to 50%. 30% is felt to be the sort of minimum target of improvement that you should see And I'll come back to that in a little bit. Now, if you haven't covered by any of one of those and you get into the primary prevention, then the issue is that if your risk is over 7.5% and you're between 40 and 75, you should start moderate to high intensity statin. And you should use this risk calculator that's online. It's not the same as the Framingham calculator that we actually have. For those of you, show of hands, how many of you are using .fram on your Maestro Care? Okay, that's an easy thing to do. You basically just type in .fram and hit return, and your Framingham risk score comes up. It's actually one of the few advantages I've seen with Maestro Care since we started using it. Anyway, it provides a very helpful way, but this risk calculator is different because it included African Americans, it included more minorities and a broader range than the Framingham has done. And we can talk about that in the discussion. Okay, so what is the high-intensive statin? It is to achieve greater than 50%, and that you will most likely do with atorvastatin 80 or rosuva 20 or 40. Those are the numbers, those are the therapies that are the high intensity. The moderate intensity are in the middle column, 30 to 50% reduction in LDL, and you can see atorva 10, 20, rosuva 10, simva 20 to 40, prava 40 to 80, and so on and so forth. Those are your moderate intensity. And then low intensity statin therapy is those giving less than 30%, and basically you can see it's simva, prava, and lova in this setting. The ones that are bolded are the ones that have been studied effectively in large trials. So there is this idea that just because we're going to do this, we'll never need to check another LDL level. I heard that the other day. Not true. These are the baseline things that you need to do before you start anything: fasting lipid panel, liver function test, CK if indicated, and then look for other causes that I'm not going to have time to get into. If you're less than 75, without contraindications or drug-to-drug interactions, then you should just initiate high-intensity statin therapy for the patients that were having vascular disease. If you're age over 75 with conditions that may influence statin safety or statin intolerance, you should initiate moderate intensity statin. You should also don't forget about the other things such as triglycerides over 500, unexplained liver function abnormalities and other things. You need to do that. And then once you start this therapy, go to the bottom, and then basically you need to assess if the patient is taking it. And remember, you want to achieve the 50, the 30 to 50, or about 30% relative reduction in this setting. If you have diabetes, you basically, or your LDL is over, I'll show that on the next slide. If you have no diabetes and LDL in their target range, you go down here, and this is how you estimate the risk for these patients. Depending on your risk, you go to either high intensity or low intensity. And it's really only patients who are low risk, less than 5%, 10-year risk, that you don't consider these therapies for in general, or if you're very young or very old, where the lipids are relatively well controlled. You really need to look at adverse effects, drug-to-drug interactions, and patient preferences. This is not cookbook. This is just giving you an idea how to go forward. And you need to monitor statin therapy on a regular basis. So obviously in primary prevention, the global risk assessment is really there to assess the 10-year risk for cardiovascular events. It's a new pooled cohort risk equation. It includes white, black men, and women. It more accurately identifies higher risk individuals for statin therapy. It focuses only on statin therapy. You may wish to avoid initiating statin therapy in a high-risk group found not to benefit for higher grades, such as higher grades of heart failure, hemodialysis, where initiating a lower grade would be reasonable. Threshold for initiating statin therapy are all derived from randomized trials. However, before initiating statin therapy, clinicians and patients need to engage in a discussion of the potential for reducing events, the benefits, the adverse effects, drug-to-drug interactions, and patient preferences. In those who are not in a statin benefit group, additional factors may inform treatment decisions. Family history of premature coronary disease, elevated lifetime risk, LDL over 160, CRP over 2, or subclinical atherosclerosis with a calcium score of over 300, or ABIs, that's sort of asymptomatic peripheral vascular disease, or less than 0.9. And here it's individualized treatment. There's no recommendations given, but it's just individualized treatment for those patients. Basically, as I showed you, the safety has been well identified. They actually allow the net benefit, estimation on net benefit from statin therapy. So the risk of reduction versus adverse events, expert guidance on management of statin-associated adverse effects, including muscle symptoms, need to be sought out. And then you have to basically look at pharmacy instructions, drug-to-drug interactions for complex cases in this setting. How are you going to monitor response and adherence? If you get the response that you expect on the left-hand side, you just reinforce continued adherence. That is to say, you measure it to see that you get a response that you need, and then you just continue down on that side. If you have less than anticipated therapeutic response on the right-hand side, you need to initiate discussion about intolerance and how you deal with statin intolerance in this setting. And here the document, I don't have time to go through this, is fairly weak because there isn't a whole lot of science in management of statin intolerance at this point. You reinforce continued adherence and you follow up 3 to 12 months later. You continue to go through this process. So essentially you're measuring cholesterol as you start a patient about every 3 to 6 months in the first phase until they're at a steady level, and then about a yearly after that. If you have a less than anticipated response, you need to have this difficult discussion about medication adherence. Did you take your medicines? Are you having side effects? And then, of course, exclude secondary causes, and then follow up on a regular basis. So the dictum is use the maximum tolerated intensity of statin. Consider additional non-statin cholesterol-lowering drugs if less than anticipated therapeutic response persists. But you should only do this in these 3 groups: the clinical patients with vascular disease less than 75, the very high cholesterol, or the diabetic patients 40 to 75. So in other patients, it's reasonable not to use the maximum dose, because in the non-statin cholesterol-lowering drugs should be used that have been shown to reduce events. Unfortunately, all those therapies are rather old in this setting. So for none of these do you need to use calculator. Those with vascular disease, those with very high cholesterol. You can use the calculator in those with diabetes with those parameters, because you can then decide on moderate versus high intensity. For primary prevention, you really do need to use it to decide who should be treatment. And you should have a discussion in the asymptomatic patients or patients for primary prevention before you start the treatment. There are some patients that may fall into this group where the LDL is less than 190 that are for the primary prevention therapy that are not identified in the statin benefit group. This is a small group of patients. You can still make a decision in this group of patients and then use the factors below, the CRP, the calcium score, to sort of define maybe a group that would potentially benefit. I'm going to skip through this in the interest of time. So this is the first guideline that come out from this. It's a comprehensive guideline. It really is very different from what we used before. The primary prevention part is patient-centered because it defines that patient's risk. And the guidelines would change every 2 years. Remember, they're now in the ACC fold but will be updated every 2 years or so. Just want to mention, though, that I've just covered that, but we have also the area of risk assessment, and here's the group that worked on that. So that's the risk calculator group. Here is the lifestyle guideline group of lifestyle changes. And I want to point out Laura Svetki from Duke was part of that group. And here is the obesity guideline with all the authors here. And the most controversial part here that the news haven't picked up on yet is the fact that bariatric surgery is recommended for patients with a BMI over 40 and diabetics over the BMI over 35, which is a monumental change to how we have done things in the past. Okay, so back to our patient. Here he is. Should we treat it with statin? I'm not going to have a vote because I sensed that nobody was going to vote for it anyway. So here is his Framingham risk score. His actually 10-year risk is 10%. This is using the old calculator. Now, show of hands here. Anybody would be interested in treating this with a 10% risk? No? Okay, maybe one. Hey, Guyton, finally. Thank you. Thank you. All right. There you go. Thank you. And here it is. And here he is. So this just proves to you that this patient actually has high lipids, non-traditional high lipids, that it would explain why he might go on to have a cardiovascular event with a near normal. Thank you, John, for all the teaching over the years. So now there is the discussion, and I want to just put two things out here. First, Yogi Berra is pretty good at this. If you don't know where you're going, how are you going to know when you get there? So you need guidelines somewhere, right? And then the other aspect of life, which is this. We're in the Wild West. We can do whatever we want.